Hi guys. I'm Will Kinsner. I'm a third-year internal medicine resident at Georgetown. I'll be presenting a case of multifocal cribriform-morular thyroid carcinoma, also known as CMTC. Um, so just to kind of get into it, it used to be considered a variant, a very rare variant of classic PTC, but that actually changed with the most recent WHO classification. And noteworthy is that it has a better prognosis than classic PTC with a lower rate of metastasis, cancer recurrence, and mortality. The one really noteworthy thing to know is that there is a very significant association with CMTC and familial adenomatous polyposis, or FAP. You can see right here. Um, and I'll talk about that a little bit later. Um, this table right here really just highlights features of classic PTC with compare and contrast to CMTC. Um, so just to get into the case, our patient is a 15-year-old female. She has no significant past medical history, including thyroid cancer, endocrinopathy, colon cancer, or significant family history of colon cancer. Um, Presented with several years of goiter and dysphagia, she was noted to be clinically and biochemically euthyroid. They obtained a large thyroid ultrasound, which showed a large nodule on the left side with several smaller ones. An FNA biopsy was subsequently performed, and that was actually concerning for classic PTC. So the patient received a total thyroidectomy, where they removed a very large mass, replacing the entirety of the left thyroid lobe with some tracheal deviation. It was noted to be 6 centimeters in its greatest dimension, with no local or distant invasion of other structures. There were no lymph nodes submitted for exam. And postoperatively, she was started on levothyroxine with a suppressed TSH as expected, um, and a serum thyroglobulin of 0.1 nanograms per milliliter with an antibody, thyroglobulin antibody less than 0.1. So several months after her total thyroidectomy, unfortunately, a radioactive iodine scan showed residual activity in the thyroid bed. So she underwent radioactive ablation with 124 millicuries. Unfortunately, the post-ablation scan revealed some thyroid remnants on the thyroid bed, and so she is awaiting further management. Down here, you can see some pictures of her pathology, which you can kind of see the caption showing those classic features. And just to get into the discussion and conclusion, really briefly, essentially, because it's such a rare entity, there really aren't great guidelines to manage CMTC. And so often the management is extrapolated from classic PTC, with a noteworthy thing being that these patients often require total thyroidectomy up front if they have a history of FAP, because these lesions are more likely to be bilateral and larger and more aggressive. And that's kind of evidenced in several case series. So really, to kind of summarize things, all these patients should be tested for FAP with a genetic screening and a colonoscopy. And more or less, we should probably be extrapolating management based on classic PTC. Thank you so much.